Hi everybody, I'm Dr. Wang from Department of Anesthesiology, Cathay General Hospital, Taipei, Taiwan. Today I want to talk about a topic about perioperative pain management, particularly on the multimodal analgesia for ERAS protocol and opioid sparing effect. As we know, in America, there's a so-called, except the pandemic of the COVID-19, as the opioid epidemic report is also very big problem for the United States. They have suffered from many drug overuse, overdose deaths continue increasing in the United States from 1999 to 2017. More than 100,000 people died from the drug overdose. In 2017, more than 70,000 people died from the drug overdose. The opioid overdose. Injury related in the United States. You can see in the 10 years, the opioid overdose increased about more than 10 times in every 50 states, and about 68% they are died from the opioid illicit drug overdose. We can see the many publications in the recent 5 years. Okay, always around the opioid prescription from chronic pain, overdose, and opioid deaths. So this is a big problem. For the post-op pain, it's very major problem for the surgery after surgery. In 2019, there's published a paper in JAMA. We can find there's a factor associated with acute pain estimation. We can estimate before surgery. Once the surgery is more pain and patient is suffer more pain, well, we can see the pain cessation for lower pain expectation will be 40 days after surgery. Even lower expectation is 40 days. For high expectation pain, and the patient is more than 92 days. So how about the opioid cessation? So for those patients who suffer expecting for lower pain, still need to 12 days for opioid. And for more pain, the opioid need to use for more than 39 days, 40 days. And patient after surgery, patient will feel, I'm full recovery from the surgery. In low pain expectation patient, they'll even still need 50 days to think I'm okay after surgery. But for the high expectation pain, it's more than 90 days. So before operation, the patient's characteristic and the surgery, the major surgery or surgery, high surgery or low surgery, the pain expectation is very important for the pain management. So there's a paper published in 2018. There's for the GYN surgery. The paper is they launched an ultra-restrictive opioid prescription protocol for pain management after GYN and abdominal surgery. What the so-called UROPP, ultra-restrictive opioid prescription protocol. They want to reduce the opioid, even opioid-free. They say opioid-free surgery, but I think it is not possible opioid-free because opioid is still very cheap and very good analgesic. If we use in the right way, in the right time, in the right patient, we still can use the opioid. So I think we should say opioid sparing anesthesia, not instead of opioid free anesthesia, because no opioid during the anesthesia, patient will feel very pain at the PACU. So I will say that there also a paper published in 2018. They say achieving the goal of opioid-free surgery, lessons learned from more than 100 narcotic-free, ERAS surgery. I think they should not say opioid-free. I still say opioid is very important drug. If you use the right time, right dose with the right knowledge, you don't have to opioid phobia. I say should be opioid phobia free anesthesia instead of opioid free anesthesia. For the ERAS protocol, the pain management is also very important I think it's a pretty major role in ERAS protocol, especially anesthesiologists can put more attention or effort on this to have a good ERAS protocol, especially for the preemptive analgesia. So the outcome of ERAS implantation, I think my colleague Dr. Guo already presented this about ERAS protocol in major surgery in our hospital. The outcome for ERAS implantation is early return to GI function, especially for abdominal surgery, satisfactory pain management with a reduced opioid, so still opioid free, not opioid sparing, not opioid free. So reduced length of hospital stays can save the money and less mobility on readmission. So patient feel no pain will not readmission. So in the ER, more than 20% is due to the pain and readmit to the hospital. So good patient satisfaction, no pain, so patient feel better, feel satisfaction. So substantial, because we can shorten the hospital stay, so substantial cost reduction. So especially more gain for the complex, the oncology, the procedures. As we know, there's a table, from anesthesiology 2018. So there's a table for it's the incidence of persistent post-surgical pain according to the surgical procedure. Amputation from have 30 to 80%. For C-section, 15%. For cholecystectomy, 3 to 56%. Hernia, up to 35%. Hysterectomy, up to 30%. Mastectomy, up to 50%. And total hip replacement, up to 23%. Thoracotomy, up to 70%. But now we more, no thoracotomy for the usually for chest surgery we use a vast, so the incidence will be lower. And this pain is almost moderate to severe pain, about 10%. For severe pains, 2.2%. For chronic neuropathic development, will up to 30 to 50% for persistent post-operative pain. So I say the perioperative pain is a matter for enhanced recovery of surgery for patient recover. So because good pain management will, patient will early ambulation and early enteral feeding and enhance GI motility and reduce post-op stress and patient comfort, shorten hospital stay, and especially reduce CPSP, chronic post-surgical pain. It's just a big problem for chronic opioid use around the world. So what anesthesia can do for this, especially I say many things can do in ERAS, but especially we can put more effort is multimodal perioperative analgesia. That's the topic I present today. It's a preventive and total analgesia, cover the pre-op, during operation, and post-op, even after discharge to the to home, So after that I would about MMA, including the route and the drug, opioid sparing anesthesia, different route, different drug, especially we can achieve, inhibit, reduce the CPSP. So the risk factor for CPSP is a pre-op factor is patient will suffer pain, and surgery expected for the moderate to severe chronic pain, and intraoperative and the surgery, now in the current 10 years, more mini invasive surgery that will be, reduce the surgical procedure in trauma, reduce the risk of nerve damage, and the inadequate anesthesia will also, for most post-op pain. So now this in Taiwan will also use the pain monitor during anesthesia. It's called ANI. I think everybody already knows this instrument pretty well. So after surgery, we need to do the continual post-operative operation, pain management, even after discharge. So post-op pain management is very important. So for the post-op pain cover for the surgery is in our hospitals around 20 to 30%. So the insight for the preventive, preemptive to preventive, because preemptive more focused on the pre-operation. So preventive is cover the whole surgery process, including after surgery recovery. So the surgical wound appears to capable generating pain input. So incision-induced sensitization will sensitize spinal cord neuron and up to the central nervous system. So we reduce maybe from peripheral to central, sensitization. Sometimes will induce the CPSP. So now I would like to talk about what is actually MMA performed in our hospital. As we know, the action of anesthesia on pain processing should be from the very peripheral, from the skin incision by surgical incision will induce pain, and to the muscle, to the peritoneum, and then the pain transduce from the peripheral nerve, and then through the to the second relay neuron in the spinal cord and up to the central nervous system, especially ACC, anterior cingulate cortex. So we can do everything in the pathway. Very beginning, we can local infiltration for the local anesthetics, or use the epidural and the peripheral nerve block, ultrasound block to inhibit nerve conduction by local anesthetic. Sometimes we will add fentanyl or opioid, and at the spinal cord we can use the epidural or intracerebral injection for different drug, but mostly we use the epidural injection in the pain management, and then we can use a systemic opioid to cover everything. However, systemic we need to give a higher dose to cover everything. So actually the side effect will increase during the dose dependent. So we can add this different area, 6 different, site, use the different pharmacology to do the pain management. So the multimodal analgesic, including local anesthetics, opioid, opioid is very important. We can spell opioid. And acetaminophen, now we use many in our hospital. So once we use the more acetaminophen use, and during operation, we can see less opioid reduction use in our PACU for the pain. And gabapentin also used in RERAS as a pre-medication, and also the post-op, the aura for after discharge use gabapentin, and NMDA receptor antagonists like ketamine, dextromethorphan, and NSAID, especially COX-2 inhibitor. So the routes and ways for pain management is systemic. We can give oral, it's a regular oral, it's a compliance good, and use PCA. We use a lot, more than 30 years or 40 years in our hospital, and intramuscular injection, but this is not very good. So we use this is a systemic 3 ways. And also via epidural, because epidural, we can use a single injection or continue PCEA, or program, the intermittent bolus. This is newly developed, actually more than 10 years, for intermittent injection, high dose, high volume analgesics. So for epidural route, there were only 1/10 to the systemic, so less side effect and more better pain management. And now in the past 10 years in Taiwan, we'll also use many ultrasound guided peripheral nerve block, like ESP block, like a TAP block for the abdominal or for thoracic surgery. And another one is, I think you probably never heard this before, because it's a newly launched 2017, I think, in Taiwan. It's a Taiwan made, it's a slow release of nabuphine. Can continue release nabuphine for 7 days, so we can give a pre-op to during operation and after discharge. Sometimes surgery will discharge 3 to 5 days. So even after discharge, you still cover for 2 days anesthesia. So this I think this can be a so-called preventive analgesics, because pre-operation 1 day before surgery will give the non-pain injection, and then during operation still slow release. After 12 hours slow release, and then extend for another 6 days after operation. So For the MMA, it's combination for the everything. Different rule, maybe two rule, at least two rule, two sides, and 3 or 4 drugs. So now the PCAs we use most and easier. So you just hook on the intravenous catheter. So patient just push the button and give the morphine. Usually we'll give morphine as in PCA, but still for opioid sparing. So I think maybe this PCA can reduce. We can use the PCEA or ultrasound block or not injection. So this is a example for continuous epidural infusion or through the program intermittent epidural bolus. We can see the PIEB better than the continuous epidural infusion because I think the background infusion is sometimes easy. Maybe can get an acute tolerance. So PIB should be better. Intermittent bolus. Also, the ultrasound guided peripheral nerve is very important. Use mostly many is top one is a TAP for abdominal plane. So now for the laparoscopic, we also use TAP for the block. At least for I think if you add fentanyl, you can last more than 20 hours for single injection. Sometimes we can give a catheter insertion for continue for days. However, catheter injection need to sometimes easy to get migration. So the fix the catheter is a very important skill. And acetaminophen and NSAID we use we use the pre-op and after operation we give oral medication as a part of MMA, so patient can easy to get and even bring it at home, to home for another days. At least as we in Taiwan we give another weeks for acetaminophen or NSAID, sometimes trauma or go home. We never prescribe opioid after discharge to home. So there's no problem for the so-called epidemic, opioid epidemic in Taiwan. And now the NMDA receptor, actually I like this drug very much because ketamine, lower dose ketamine, sub-analgesic ketamine, like a 0.25 or 0.5 milligram per kilogram ketamine during operation can reduce, the post-op at PACU opioid use. In my patient, I always give around 50 milligram during operation, still immediately after general anesthesia induction. So I can see my patient at PACU there's a less pain and less opioid use. Hopefully, it's an NMDA receptor will inhibit chronic pain development. So prevention PPP or CPSP, I think NMDA is very important. Also, the oral antitussive cough medicine, dextromethorphan is also the NMDA receptor channel blocker. You can use the prescribed as an oral medication, like patient bring home. So gabapentin is also very important. I like to use a pre-op and after operation. However, patients sometimes will feel heaviness or sleep disturbance. So sometimes when you prescribe this, you need to ask your patient not go driving, go out. So stay at home will be better. But in my MMA, I use 100 milligram TID, 3 times a day. But in combination with other drug will be okay. We don't need to use the 600 milligram as a suggested in many guidelines. So melatonin is recently I do many research on melatonin. It's best actually it's this very just for it's very good for sleep, and also it's have the anti-inflammatory action, especially enhance opioid use, morphine's effect. So melatonin is also very good for pre-op, good patient sleep, and also for after operation, to help patients have good sleep quality and also enhance opioid effect as opioid sparing effect. So the major now at last, I think the major analgesics for surgery, especially for major surgery, because surgical pain is very severe. up to usually from 6 to 10. VAS score from 6 to 10. So you must use opioid as a major, the main analgesic, especially in the hospital post-operation, the first 5 days. The opioid have a mu and kappa and delta receptor. Now I want to, I think mu opioid receptor like fentanyl or morphine, everybody knows pretty well. Now I want to introduce the nalbuphine. Nalbuphine is very also pretty equal potent to morphine, but low dose, nalbuphine for intermittent injection will enhance morphine's effect, not just block. It's a mu antagonist, kappa agonist, but nalbuphine will antagonize mu's analgesic effect. But from kappa agonist effect, he will, to cover its reduction. However, can reduce morphine's side effect. So we use the nalbuphine sometimes with morphine where you inhibit morphine's side effect. However, not reduce opioid analgesic effect. Now in Taiwan, I just mentioned in 2017, we have a new drug launched on market in Taiwan. We call it nalbuphine. Nalbuphine slow release is a Nardoban. Once injection, the Nardoban 150 milligram intramuscular injection. I say intramuscular because it's a lipid soluble. So if once you give the intralipid injection, it will not work and even cause injection pain. So you must inject this Nardoban intramuscularly. After 12 hours, it will slow release reach to the peak concentration, 3.6 for effective analgesic concentration, and can last for 7 days. So once 12 hours before surgery, you can give 7 days analgesic effect. So after surgery, still can for cover at least 5 days, sometimes to 6 days for moderate pain. So this is my conclusion. So in ERAS protocol, especially for perioperative pain management, for before operation, we need to assess patient's risk factor. We give a preventive analgesia. 1 day before surgery, we can give oral gabapentin, the dextromethorphan, ketamine, just NMDA antagonist, and also COX-2 inhibitor cerebrus, or Nardoban injection for preventive and preemptive analgesia. And this drug can keep intraoperation. We need to use a local anesthetic. We usually in our ERAS protocol, we will always use epidural catheter insertion. So we can, during operation, we can use local anesthetics and the sedation during operation. So epidural anesthesia and general anesthesia. And then we use a pain monitor, just adequate nociception inhibition, use ANI as an inhibit monitor. And post-op, we use the multimodal analgesia, especially we use continuous epidural or PIEB with oral analgesic like acetaminophen, NSAID, or COX-2 inhibitor. So after discharge, also prescribe oral medication like gabapentin, neurontin, low-dose gabapentin, acetaminophen, or sometimes tramol. And then if we give intramuscular injection of Nardoban, you can keep another, after operation, we keep another 6 days. So now here's a case report I use for the cuff surgery, a rotator cuff surgery. So we give Nardoban, the oral medication before operation. For I use neurontin, gabapentin 100 milligram, and then use a dextromethorphan 60 milligram, and COX-2 inhibitor cerebrus 200 milligram pre-op. I give 12 hours and 2 hours before surgery for the drug, for these 3 oral medication. And then we use the ultrasound guided nerve block for the for the peripheral nerve block. And then we use the multimodal analgesia for Nadabane. We use Nadabane 1 day before injection, before surgery injection. So after surgery, they will already reach to the effective analgesic concentration. And then after operation, we give a catheter insertion for the ultrasound block, and then with Nadabane, so we can cover the for more than 5 days after surgery. So instead of like a regular post-op analgesia, after surgery, when we feel pain, we give analgesia, and then the level is too high, maybe induce the side effect. Once the drug concentration decrease to the effective concentration, and then feel more pain, and we give more drug and more side effect, and then the drug, analgesia will cannot lower than 5 because more side effect. So more than 5, and then we'll induce the CPSP. Once we cover the pain from pre-operation, during operation, and after operation, and after discharge. So the pain score always lower than 3, so we not induce the CPSP. So that was this multimodal analgesia, pre-op oral medication, Nadabane injection, and then during operation with ultrasound block, and then after operation we give oral medication and Nadabane for another 7 days. So this is I think it's a very ideal protocol for MMA in this particular surgery, rotator cuff surgery. Okay, that will be my talk. Thank you.